So we've discussed about oral cancer in detail, and to end this module, I would like to discuss a case of an oral lesion so that it helps you to understand how exactly we work up a patient, we treat the patient, and also what are the differentials which can be there when we are seeing such a case in our OPD or clinic. So we have a 36-year-old gentleman who's a chronic smoker and tobacco chewer. Now, it is very important that when as a final year student, if you're presenting your history to the examiner, if you mention this upfront, the examiner will be impressed. Because, then the examiner starts thinking that you're thinking in a certain direction, and it is always better that you do this if you know that you're dealing with a case of malignancy. The patient has a lesion in the oral cavity since the last 2 months. It was insidious in onset, rapidly progressive. So this term is important. Rapidly progressive, again, it hints towards a malignancy for us. Patient had burning sensation in the area during meals, especially after spicy food. Because it's a raw area, that's why he's having this burning sensation. 2 episodes of mild bleeding from the lesion as well. So again, because it's a raw area, sometimes bleeding can happen from these malignancies. There is no history of trauma. This is important. Dental intervention. Why is this negative history of dental intervention important? Because you know that having dentures, constant irritation because of a denture can also predispose to a malignancy. So taking this negative history is important. And loosening of teeth. Why is this important? So if the mandible or the maxilla is involved, then there can be loosening of teeth as well. Or if the malignancy is involving the bony structures, then the teeth can also become loose. There's no history of fever, no history of excessive salivation. Why is this important? Because it's a raw area, there can be constant irritation, and some of these patients with cancer can have increased saliva production. Not in this case, but it can be there. There is no difficulty in mouth opening, tongue protrusion, chewing, swallowing, and no alteration in speech. Very, very important history. Why? This is for the clinical nerves, right? These are for the cranial nerves. All the cranial nerves, we've elicited the history for them. Difficulty in mouth opening, deviation, tongue protrusion. This confirms our cranial nerve history. No history of headaches, seizures, breathlessness, cough, hemoptysis, bone pain, and jaundice. This is for metastasis, the negative history. No history of loss of weight or appetite. No history of contact with multiple sexual partners. You know that secondary syphilis can give rise to oral cancer, so you have to take this history as well. A biopsy was done 1 month back for this patient, and past history, there's no history suggestive of systemic illness, no history of surgeries in the past, no history of oral malignancy in the family. He's a tobacco chewer for the last 15 years, smokes half a bundle of BD a day for the last 5 years, no history of consumption of alcohol, and he's non-vegetarian. So this is the entire history which you take in detail. I've told you the negative histories as well. In our previous case discussions also, I've explained to you why negative history is important for us. So on examination, we have an alert, conscious, cooperative patient of average build. Vitals are stable. Nutritional status and hydration status is adequate. Performance status is 90 by Karnofsky. Now this performance status is very important, not only for the entrance exam, but for your viva as well. This tells us about the functional status of a cancer patient. Functional status of cancer patient, we get to know by the performance status. How functional is the patient? Can he do his daily activities? Can he do normal activities? Or the patient is bedridden? So one of the scores to assess performance status is known as the Karnofsky score or Karnofsky index. The Karnofsky score, no evidence of disease, is 100. If the patient is doing normal activity, 90. Moribund patient, it's a score of 10. So ranges from 100 to 10. You have another score known as the ECOG score. This is the Eastern Cooperative Oncology Group score. Eastern Cooperative Oncology Group score, and this is from 0 to 5, right? This is the ECOG score. These are the two scores for performance status, which you should know. Now, if we talk about the local examination, I'm describing it first, but I have a video which I'll show to you of all these signs which I'm mentioning here. The facial symmetry is maintained. This is how you start with. I've told you in the past as well, don't get fixated on the ulcer only. Describe the patient as a whole. That is what the examiner is looking for. So facial symmetry is maintained. Mouth opening is adequate. This is important because you can have submucous fibrosis and that can prevent mouth opening. Some element of submucous fibrosis is present. Halitosis, foul odor is there. Tobacco staining of teeth is present. Dentition is normal. There are multiple leukoplakic and melanoplakic patches. You know these are pre-malignant, and I've told you in the module about field cancerization. That means multiple cancers can arise later on in the oral cavity in the same patient. You have an ulceroproliferative growth over the left buccal mucosa measuring 5 into 5 centimeters, extending from the second molar and stopping just short of the trigone, retromolar trigone. Necrosis is present, no active bleeding is there, and there are well-defined margins and everted edges. So let's see the video of the patient and see all these points which I've just mentioned. So you can see here that the facial symmetry is maintained. Patient has adequate mouth opening his mouth adequately. And now that we are zooming in, you will see the oral findings which I've mentioned. You will see the tobacco staining. This is tongue protrusion is normal. There's no deviation of the tongue. So you know that the hypoglossal nerve is normal. Now you can see that there's tobacco staining of the teeth which is present. There are multiple melanoplakic, these darkish patches. You can see that the uvula is being lifted in the midline. It's not getting deviated to one side. Again, a cranial nerve test. Tongue protrusion is normal. You can see the ulceroproliferative lesion extending from the second molar, stopping just short of the retromolar trigone. No active bleeding is there. This is the submucous fibrosis area. Right, so you can see the lesion here. And the tobacco staining of the teeth can also be seen. This is palpation of the lesion. You are seeing if it bleeds actively on touch or not. What does the base look like, or base feel like? I'm sorry. You know that floor is what we see and base is what we feel, right? So you have to do that. Again, you can see that the tongue can go right up till the hard palate. So no restriction in tongue movement. Again, a sign that the cranial nerves are not involved. Let's look at the next. So you can see that patient is showing his teeth and there is no deviation of the angle of the mouth. So the marginal mandibular nerve, the facial branches are all fine. This is where you can see the lesion. Again, tongue protrusion is normal, no deviation of the tongue. Opening of the salivary gland ducts is normal. 9, 10th, 11th, 12th cranial nerves, I have demonstrated in that examination video. They are all normal. This is commonly asked in the exam. How do you demonstrate each? I've told you. There is a single mobile lymph node. There is a single lymph node in level 1B. You know, 1A submental, 1B submandibular group measuring 1.5 into 1 centimeters. ENT examination you have to mention is normal. TM joint examination is normal. And systemic examination is normal in this patient. Now, once you finish the history and physical examination, the examiner is going to ask you for a summary. So the summary has to be in 2 or 3 lines. 36-year-old chronic smoker and tobacco chewer with a rapidly progressive ulceroproliferative lesion in the left buccal mucosa with a single mobile lymph node on the same side, with no clinical involvement of cranial nerves or contiguous structures. That is the summary of your case in 3 or 4 lines. That's what you have to tell your examiner. Okay? He'll ask you what is your impression of the case. The impression is it is probably a malignancy of the left buccal mucosa, stage T3N1 MX. A better answer is if you say MX then MO. Why MX? I explained to you when I was telling you about TNM. MX is when METs cannot be assessed. Clinically, I cannot assess METs. So writing MX would be better. Again, as we've discussed in previous clinical discussions, how do we proceed? We'll do investigations to confirm the diagnosis. So to confirm the diagnosis, we'll do a biopsy. Now, whether this is a incisional biopsy or excisional biopsy, in the module I've told you, we'll always take a wedge biopsy from the margin, right? That means the junction of normal and abnormal, and it'll be a edge or a wedge biopsy. We don't do an excisional biopsy here. It is an incisional biopsy which will be taken, edge or a wedge biopsy. Then we'll do investigations to stage the disease. We'll do a CCT of the paranasal sinuses, neck and thorax. And investigations to treat the disease, you'll do the routine PAC workup for the patient so that the patient can undergo surgery. T3N1, you know, because it is more than 4 centimeters in size, so it is T3. And single lymph node which is less than equal to 3 centimeters is N1. So T3N1 is the stage. The management, as we've discussed in the module, is going to be a wide local excision. And what margin are we looking for? Even 0.5 centimeter margin is enough. We'll do a modified radical neck dissection on the same side, and we'll do a reconstruction. Reconstruction is most commonly done using the PMMC, pectoralis major myocutaneous flap. And if the node is positive on histopathology, patient is also going to get chemoradiation later on after surgery. This is the post-op image after resection. You can see once we've resected, this is what it looks like. Again, after resection, this you know is the modified Schubinger's incision for neck dissection. This is the modified Schubinger's incision for neck dissection, which we use for carrying out neck dissections. Neck dissections, I've told you in detail in the module. We'll do a modified radical neck dissection in this patient. So this was a clinical case of an oral lesion and also the description of an ulcer. I want you to appreciate all the points I've included here in describing the ulcer as well. Thank you.